Welcome to the Explainer. So, whether you're actively cramming for your IMM or CPSB board exams, or honestly just gearing up for your next intense shift in the trauma bay, you're going to want to consider this your ultimate high-yield study tool. Today, we're completely mastering the grading of open fractures. I promise by the time we finish this, you'll be able to look at a complex injury and literally instantly know its classification, its risks, and exactly what you need to do next. Let's get right into it.
Okay, let's dive into this. Here's how we're going to climb the ladder of severity step by step. First, decoding the Gustilo-Anderson classification, then breaking down type 1 and 2 fractures. After that, we hit type 3, the really severe fractures, look at targeted antibiotic protocols, and finally wrap up with some high-yield exam pearls. Section 1, decoding Gustilo-Anderson. Because, before we even try memorizing the types, we really have to understand the foundation of this whole classification system.
So, the Gustilo-Anderson classification, it's essentially the most widely used system globally for grading open fractures. And it's based on some highly specific wound and tissue characteristics. And I really want to stress here, this isn't just some arbitrary list created for textbooks. No way. This is absolutely a crucial, detailed tool that orthopedic surgeons rely on every single day to make those split-second decisions right in the trauma bay. Now, take a really good look at the slide here, and honestly, just commit these 5 core variables to memory. They're everything. Every single fracture gets evaluated on the size of the wound, the degree of soft tissue injury, the level of contamination, the extent of periosteal stripping, and of course, vascular injury. These 5 parameters literally dictate every medical and surgical decision you make moving forward.
So what does this all mean in practice? Well, mastering those 5 variables directly empowers you to determine these 4 life-changing outcomes for your patient. By getting the classification right, you immediately know their infection risk, the exact antibiotic choice they need, whether you need to call plastic surgery for flap coverage, and their overall prognosis for limb salvage. It is a real game changer. Section 2. Type 1 and 2 fractures. These are your baseline fractures. Sure, they're lower energy, but they still require incredibly precise clinical categorization. Now, what's really interesting about this slide is the side-by-side escalation. On one hand, you have type 1. We're talking a tiny, clean wound, less than 1 centimeter, with very minimal soft tissue damage. Then, type 2 steps it up. The wound is bigger, right, between 1 and 10 centimeters, presenting moderate soft tissue injury, but actually still minimal periosteal stripping. So we're moving from just a tiny, simple puncture to a moderate, albeit manageable wound. All right, pay attention, because here's your first major exam pearl. A classic inside-out injury. That's where the bone actually pierces the skin from the inside, creating a small, super clean puncture. That is the absolute hallmark of a type 1 multiple-choice question. It's a highly straightforward fracture pattern with an incredibly low infection rate. We're talking literally just 0 to 2%. Building directly on that, your type 2 exam pearl usually features a wound larger than 1 centimeter. But, and this is absolutely crucial, it still has adequate soft tissue coverage. You'll notice the infection rate starts to climb a bit here, sitting around 2 to 7%. But hey, you can totally reassure your patient, and yourself on the exam, that flap coverage is still not required here. Good old surgical debridement and fracture fixation will get the job done. Section 3, type 3, the severe fractures. Okay, shifting gears a bit, because we are now entering the high-energy, very high-risk territory of type 3 fractures. Things get serious here. To really set the stage for these type 3 subcategories, just look at the uniting factors here. We're dealing with massive, high-energy injuries, really extensive soft tissue damage, severe contamination, and highly comminuted fractures. Basically, the bone is in pieces. This inherently means a ridiculously high infection risk right out of the gate. So let's break this down further, starting with type tier 3A. And this brilliantly illustrates a really vital concept. Despite the horrific, extensive soft tissue laceration you might see coming in from a farm injury or a nasty road accident, type tier 3A specifically means that adequate soft tissue still remains to cover the bone. Even if that bone is glaringly exposed initially, it can still be completely covered after debridement. Let's drill this in, guys, because this is a massive, high-yield exam pearl. If you're reading a test question detailing a truly severe injury, but you spot the magic words adequate soft tissue coverage, your brain needs to immediately lock on to type 3A. The infection rate here is definitely higher, hovering around 7 to 10%, but coverage is possible. Now contrast that directly with type 2IB. Check out these criteria. extensive soft tissue loss, major periosteal stripping, and exposed bone. The defining factor here? The bone absolutely cannot be covered without flap reconstruction. We're talking massive contamination, severe crushing injuries, likely multiple debridements, and the absolute necessity of an emergency plastic surgery consult. And here is your specific Type 2 IBA exam parole. Flap coverage required equals Type 2 IB. Notice that staggering jump in the infection risk here? It absolutely rockets up to between 10 and 50%. That massive, scary risk is linked directly to the requirement of a rotational or free muscle flap just to get that exposed bone covered. So the crucial point is this: a vascular injury instantly trumps all other criteria, period. That brings us to Type 3 IC. By definition, this is any open fracture associated with an arterial injury that requires repair. It completely ignores wound size. I don't care if the wound is barely visible. If an artery is blown and needs emergency repair, it's an automatic Type 3 IC. Listen, make no mistake about this. A popliteal or brachial artery injury means major limb ischemia. This exam parole warns us that an arterial injury needing repair not only defines Type 3C, but it carries the absolute highest amputation risk among all the types. You are staring down emergency vascular repair and very likely a fasciotomy to try and save that limb. Section 4. Targeted antibiotic protocols. So we've covered the anatomy of the injury. Now let's quickly pivot to the immediate medical management, focusing on targeted pharmacology. Let's move to and see how this builds a perfectly escalated defense. For your milder Type 1 and Type 2 fractures, a reliable first-generation cephalosporin like ceflazoline is your go-to. But once you hit the severe Type 3 categories, A, B, or C, you absolutely must add an aminoglycoside like gentamicin to that ceflazoline. And definitely pay special attention to the bottom row here. If it's a farm injury or there's any fecal contamination, you've got to add penicillin specifically for Clostridium coverage. Now this right here is an incredibly detailed visual breakdown. It's a maximum detail graphic that perfectly maps out the entire escalation of severity in one single grid. Honestly, I highly invite you to take a screenshot of this right now. You can trace the wound size from under 1 centimeter all the way to massive tissue loss, watch the bone coverage literally disappear in Type 3B, and see exactly how the vascular injury instantly isolates Type 3C. It's all right there. Section 5. High-yield exam pearls. All right, let's bring the energy up for a rapid-fire review. Consider this the ultimate test of your immediate recall for those IMM and CPSP board exams. Let's see what's stuck. Okay, I've got 2 classic Viva questions for you. I'm going to ask them, and I want you to mentally lock in your answer before I reveal it. Ready? Question 1. What is the most important determinant of a Type 3 IC fracture? And question 2. Which type specifically requires flap coverage? Take a second. Got your answers? Okay, let's see how you did. Let's validate those answers. The sole determinant of Type 2 IC, that's an arterial injury requiring repair. Spot on. And the type that strictly requires flap coverage, that is Type 2-3. And hey, just remember the rule of threes for the absolute highest infection risk. It's always your Type 2-3B and IC fractures. We're going to conclude with this golden rule. Arterial injury overrides all other findings and makes the fracture a Type 2 IC. It literally doesn't matter if the wound is a tiny half-centimeter puncture. If that artery is compromised, the entire limb is on the line. Which actually leaves me with one final question for you. After mastering this incredibly detailed breakdown today, are you prepared to spot that tiny limb-threatening arterial puncture on your very next clinical shift? Keep these visuals handy, and I know for sure you will be. Thanks for exploring this explainer with us, and we'll see you next time.